Definition: myocardial infarction is a coagulative necrosis of the cardiac muscle and is due to prolonged severe ischemia. Risk factors: age. Its frequency rises progressively with age and peak is between 40 to 60 years of age. It can develop in younger patients with major risks of atherosclerosis, hyperlipidemia, hypertension, diabetes and cigarette smoking. Sex. Males have significantly higher risk than females, mainly during the reproductive period after menopause. The risk is similar to that of males. The protective factor may be estrogen. Pathogenesis. Acute plaque change. Morphological changes occur in this: a. Rupture and fissuring of plaque. b. Erosion or ulceration of plaque. c. Hemorrhage into central core of plaque. Factors triggering acute plaque change. Intrinsic include plaque composition and structure. Extrinsic include blood pressure, platelet reactivity. 2. Formation of microthrombi. 3. Vasospasm. 4. Activation of coagulation pathway. 5. Complete occlusion of vessel. 6. Myocardial occlusion. Consequences of myocardial infarction: reversible injury, irreversible injury, biochemical changes, functional disturbances, morphological changes, seen in both reversible and irreversible injury. Pattern of infarction: 1. Transmural infarction. In this street elevation myocardial infarct. By occlusion or epicardial vessels. Caused by combination of coronary atherosclerosis, acute plaque change, and superimposed thrombus. 2. Subendocardial infarction, seen in severe reduction in BP as in shock, chronic coronary stenosis. 3. Multifocal microinfarction, in microembolization of small intramural vessels. Vasculitis. Endogenous elevated level of catechals. Gross changes in myocardial infarction. 1. Within first 12 hours. No apparent gross changes are seen. Tripenyl tetraethylium chloride can grossly identify infarct within 2 to 3 hours onset. Non-infarcted myocardium appears brick red. Infarcted area remain unstained pale. Old infarct appear white and glistening. Second is, by 12 to 24 hours. Grossly identifiable, appears pale reddish blue area due to stagnated blood. Progressively becomes sharply defined, yellow tan and soft. 3. After 3 to 5 days. Mottled with central pale yellowish necrotic region with demarcated well border of hyperemic zone. 4. By 10 days to 2 weeks, appears soft. Rimmed by hyperemic zone of highly vascularized granulation tissue. 5. After 2 weeks. Older, healed infarct appear firm, pale, gray and contracted, develops into fibrous scar. Morphology. Most transmural infarct involve at least portion of left ventricle of interventricular septum. Isolated infarction of right ventricle are rare. Pattern of left ventricular infarcts: 1. Left anterior descending coronary artery occlusion, 40 to 50% infarct. Involve anterior wall of left ventricle near apex. Anterior portion of ventricular septum. Apex circumferentially. Second is right coronary artery occlusion, 30 to 40% infarct involves region of inferior or posterior wall of left ventricle. Posterior portion of interventricular septum. Inferior or posterior right ventricular free wall. Complications: 1. Contractile dysfunction. 2. Arrhythmias. 3. Myocardial rupture. 4. Ventricular aneurysm. 5. Pericarditis. 6. Infarct expansion. 7. Mural thrombus. 8. Papillary muscle dysfunction. 9. Progressive late heart failure. Lab diagnosis of myocardial infarction. Enzymes: 1. Myoglobin. 2. Troponin T peak at 12 to 48 hours. 3. Troponin I peak at 24 hours. 4. Creatine kinase. 5. Aspartate aminotransferase AST. 6. Lactate dehydrogenase.